A pleasant morning, everyone. It is my honor to welcome all the participants and the audience, especially our professor, Ms. Vilma Geronimo. Before I proceed to the introduction of the participants, have you ever heard about brain stimulation? If you never heard about it, let me tell you a short background of it. Did you know that this entails the placement of the electrodes in the specific part of the brain? The electrical impulses are generated by these electrodes, which are used to moderate excessive impulses. Alternatively, electrical impulses in the brain may alter specific cells and substances. This equipment is connected to the electrodes in your brain by a cable that runs under your skin. That's quite a long background about brain stimulation. I hope you're still listening. We haven't reached the half of our program. I don't want you to wait more, so I will now introduce all of you, the debaters for today's debate. Computer programming. Smyle Abejon, Edrelyn Padilla, Faye Quibuyen, and Jullane Mae Buquid. The debaters for the garments and fashion design. Alexies Perez, Joy Lagman, Pamela Ventura, and Jonnah Monserrat. Here are the mechanics. Each debaters will be given 1 minute and 30 seconds duration. Remind every debaters to not use bad words. I think each debaters are ready, so now let's start the debate. Debaters, let's give them the information that they deserve.
Are you ready? 1, go.
Starting in 2005, Mae Buquid published a series of pilot studies that shown promising outcomes, with around 40% to 60% of patients responding to treatment, as shown in clinical trials full results, finally published in 2017. Many of trials patients who didn't initially show improvement eventually recovered after prolonged treatment. We agree that brain stimulation can help the patient's situation to lessen the symptoms, because once the brain stimulation works, the symptoms will improve significantly and also improve mood and quality of life and increase overall energy level. This can help to treat a number of conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, and obsessive-compulsive disorder.
Let's say, brain stimulation can treat some of the brain problems you mentioned. But are you aware that deep brain stimulation involves creating small holes in the skull to implant the electrodes into brain tissue, as well as performing surgery to implant the device that contains the batteries under the skin in the chest? And also, Mayo Clinic says complication of surgery can be the cause of bleeding in the brain, stroke, infection, breathing problem, heart problem, and seizure. With appropriate intervention, 51% of patients complained of failed DBS procedures. 34% of these patients had persistently poor outcomes despite maximal intervention. This case series provides important insights into reason for DBS failures and proposes strategies to patients with DBS more effectively. Therefore, those who have been cured by the brain stimulation are not enough to immediately agree on this issue.
On my side, DBS, or deep brain stimulation, is responsible for the movement symptoms, or so-called motor symptoms, that caused by Parkinson's disease. Yes, there are many complications when it comes to brain stimulation, and I guess that's normal, because most of them are not tolerated by the body. Unlike some other surgical options, DBS does not cause permanent damage in any part of the brain. In fact, it lasts 11 to 15 years and is often accompanied by improvement in quality of life, include things such as feeling better emotionally, feeling less embarrassed in public, moving about more easily, having less position discomfort, and having less medication.
Yes, indeed. Having some side effects after surgery is normal, but there are some cases where brain stimulation can cause death. Based on research entitled Long-Term Mortality Analysis in Parkinson's Disease Treated with Deep Brain Stimulation, there is also a study that states some cases of death after the surgery. In 14 patients, there were 16 significant adverse events associated with surgery. 2 perioperative fatalities occurred, one from pulmonary embolism and the other from aspiration pneumonia. 2 pulmonary embolisms, 2 subcortical hemorrhages, 2 chronic subdural hematomas, 1 venous infarction, 1 seizure, 4 infections, 1 cerebrospinal fluid leak, and 1 skin erosion were among the additional adverse events reported. Permanent sequelae were found in 4.6% of cases. Device-related problems such as infection or skin erosion were also reported in 4.6% of cases.
It's depending on the person's illness and physical strength if they can handle the deep brain stimulations. So not everyone who uses deep brain stimulations dies. According to the research, mortality after surgery, deep brain stimulations for patients with Parkinson's disease, the survival of PD patients has been investigated. Many researchers reported that the mortality rate of PD patients is higher than the general populations. So 27 and 16.9% PD patients, 13 men and 14 women, has died by May 10, 2015. In the mean follow-up, the period of 4.9 and 3.1 years after DBS surgery. So the survival rate was 97 at 3 years after the DBS surgery and 85% at 5 years after DBS surgery. And also the most common specific cause of death is pneumonia.
Brain stimulation have different types, which includes the DBS, which is what you only emphasize in your arguments. As the third speaker from opposing side, I'll be discussing the two among the types of brain stimulation, as well as my arguments why we disagree with the motion. First, we have the ECT, which has 70 to 90% of patient survival rate. However, I provide an evidence that ECT has low effectiveness. According to Mind Zero, some people experience more long-lasting or permanent memory loss, which I will also support claims from TED-Ed. A YouTube channel explains that ECT might affect some people for forgetting previous or earlier events after sessions. Also, one from comment section, Dana Quintela, tells how her mother got dyslexia, multiple fractures, and malfunctioned body organs after surgery until now. Next is the well-known DBS, which focuses your arguments that according to you is very effective. Here are evidence that performing DBS corresponds a very risky effect. Findings in the research of Barbara Diakina and other researchers in interdisciplinary neurosurgery claim that accessory nerve injury after DBS is an uncommon complications reported in few studies. In one of them, patient failed to improve after 2 years of post-operatively follow-up. Also in the study of UFH in 2005, researchers published a seminal study on DBS failures. EPR claims that there is 51% of survival rate, would you accept the 49% of failure in the session?
Yes, you are right, that 49% of people do not survive DBS, but the most importantly, more people survive that treatment. 49% of failures from the session may be the elderly that have Parkinson's disease that the body may be no longer handle. There is still 51% of people survive DBS treatment, though DBS is considered as an alternative, well-established, FDA-approved technique that has been used to treat Parkinson and essential tremor for 30 years. There's been a lot of studies over the years, said Dr. Seth. DBS is more effective than the best medical therapy, so that the appropriately chosen patient, DBS can be very successful at improving tremor for essential tremor and tremor stiffness, rigidity, and those other motor symptoms of Parkinson's disease. According to 2019 study published in the Journal of Neurosurgery that addressed long-term outcomes for DBS patient satisfaction, however, remained high. 92.5% happy with DBS, 95% would recommend DBS, and 75% felt it provided symptoms control. The study also observes that more than a half of Parkinson's patients who receive DBS survives for 10 years or longer.
Let's say that brain stimulation is effective. But did you know that brain stimulation costs? The cost of deep brain stimulation, including physicians and MRIPs, is around $30,000. When a doctor recommends this procedure, it is usually covered by insurance, but patients should double-check coverage and copays with their insurance company. Despite the overall effectiveness of DBS, observational studies and subgroup analysis of trial data demonstrate that not all patients report improvements in QAL. Daniels et al. 3 found that 43% of patients show no improvement at 6 months, and Suarez et al. 4 found that 37% show no improvement or a decline in QAL. For composite indices and individual domains of global disease-specific, e.g., Parkinson's disease questionnaire PDQ-39, and generic QAL measures, there are aggregate improvements in motor signs, mobility, activities of daily living, stigma and bodily discomfort, and no improvement or decline in social support, emotional well-being, cognition and communication. 4 to 7 studies that have quantified patient responses perceived outcome at 3 months. Post-surgery show positive ratings in only 47% and 37% of patients and spouses respectively.